Anu, what we were really keen to, so first of all, huge thanks for doing it, and huge thanks for juggling your busy life. And
no problem.
you know, we you know, many of us have got kids, so we know what it's like when they A, get ill, or B, start playing up, or whatever reason. You know, you just have to be flexible.
Yeah.
But what we're particularly interested in is hearing about your career, and also I'm delighted that you're going to tell us about your PhD, because it's a really important topic for all radiologists. But we're also hugely interested to hear how you went about setting it up, and how you got people interested, and also how you got funding for a PhD for that topic. It's great. Yeah. So listen, I'm going to stop
No, that's all right.
wittering on, as my husband would say, and hand over to the main event here. So Anu, we're delighted that you're speaking to us. We'd love you to come to Cambridge some point, and come and meet with us and things. That would be fab. But over to you. Tell us about you.
Thank you so much. Hi, good evening, everybody. Thank you for everybody that is tuning in and that's there physically. I really appreciate the opportunity to have a chat with you this evening. I'm going to be talking about something that has become very dear to my heart, which is training and education in CTC. So I'll give you a little bit of background as to why I think it's important, and then how I've been involved in this work. And as Prof has mentioned, I'll kind of interject a little bit how I've gone about the research and what we've been able to accomplish over the last few years. So what I intend to cover is just a very, very brief overview of colorectal cancer, the two main investigations that we use to investigate it, what the challenges are, and how that has led to the research that I've been doing for my PhD, and then the creation of the National CTC Training and Accreditation Programme, of which I'm the online training lead. So just a little bit of background. As I am certain that you will be aware, colorectal cancer is different from breast and prostate cancer in that it is preventable. It's preventable by identifying and removing what we call the precursor polyps. And these polyps are take about 5 to 10 years to turn into a cancer, if they're going to turn into a cancer. And so it makes colorectal cancer really unique in that it can be prevented by removing these precursor polyps, and by detecting it earlier, we can improve our patient's prognosis. So what we're really trying to do is detect the polyps here in this side of the growth process before they become malignant and invasive lesions. So the two main ways that we investigate the colon are colonoscopy and CT colonography. And both of those investigations allow us to see the whole colon, allow us to see inside the bowel, and we can detect any of those polyps. And these are the two investigations that are primarily used in screening and diagnosing our symptomatic patients. So if we do a comparison of CTC, which is CT colonography, and colonoscopy, obviously I'm biased because I'm a radiologist, but CTC is less invasive than colonoscopy. It's a quicker examination to do, and it requires less bowel prep, less aggressive bowel prep. As I mentioned, we don't have to sedate our patients. And now we routinely use low dose protocols. The radiation dose was used to historically be the main disadvantage and the main thing that the endoscopists would use as the primary benefit for colonoscopy, driving patients towards that. But also we see less adverse effects of CTC. There's less risk of perforation than in colonoscopy. And really for the sensitivity for diagnosing colorectal cancer is comparable between the two investigations. The main difference is that colonoscopy allows you to also get a tissue diagnosis, obviously, because you can take a biopsy at the time of the investigation, which we can't do with CTC. Now, when we talk about the images or what we get from the investigation, I've put up here the same lesion, the view that the endoscopist has, which is here, which is the colonoscopy view, our view on a CTC, which is our standard 2D CT images, And in CTC, what we also do is that reconstruction, so a 3D view of the inside of the bowel, which we call the endoluminal view. And as I'm sure you can appreciate, the endoluminal view and the colonoscopy view are pretty comparable, which is why CTC is so cool. So now we're generally accepted as a sensitive and cost-effective investigation, which can be used to diagnose our symptomatic patients and as part of the bowel cancer screening program, specifically in patients that cannot have a colonoscopy. So if we consider some of the challenges we have with colonoscopy, so even before the pandemic and the impact that that has had on all of our waiting lists, the endoscopy services were really overstretched, and there's been a 12 to 15% increase in all endoscopic activity, but with the biggest increase seen in colonoscopy here and flexible sigmoidoscopies. Now, when you look at the reasons why endoscopy aren't meeting their waiting list targets, it's primarily due to endoscopy capacity. So waiting times have gotten worse because we don't have the capacity to do all of the colonoscopies that we need to do. And then when you overlay the pandemic, things are even worse. So these figures are just a year old. So August last year, there were over 85,000 people on the waiting list for a bowel cancer investigation, and 42% of them were waiting more than 6 weeks for their colonoscopy or flexible sigmoidoscopy, and that's compared to only 10% before the pandemic. And they've hypothesized that this delay in diagnosis is going to cause an extra 1,500 deaths due to bowel cancer in the next 5 years, which is about a 16% increase. So COVID has had a massive impact on the 2-week wait pathway. And as we're kind of going through our COVID recovery phases, we're seeing more and more people presenting who have kind of held on to their symptoms and not come forward earlier. Now, CTC offers us an alternative diagnostic pathway to colonoscopy, and we perform more than 100,000 CTCs across the country each year, and it accounts for about 20% of all the whole colon investigations. So one of the massive disadvantages that we have with CTC is that there's been huge investment into colonoscopy and the endoscopy services across the country, which has really helped to improve the standard of endoscopy. And colonoscopists have really clear performance metrics. They have to be accredited to be part of the bowel cancer screening program, and they're very tightly regulated and monitored. And that is very different to what happens in radiology and what happens specifically with CTC. So although most radiographers and most radiologists have done some basic training, which I'm going to discuss a little bit more later on, there isn't any accepted accreditation or even mandatory training for you to report CTC scans as part of the bowel cancer screening program, or even just generally. And as a consequence, what we see is a massive variability in the quality of CTC services across the country. So that takes us on to the importance of training and my PhD research. So I was fortunate enough to be employed as a research fellow at St Mark's Hospital, and I was in a rather unique position in that I applied to do the PhD and funding had already been obtained. So I was basically walking into a job that had resource already and a kind of plan of, Anu, we'd like you to look at radiologist performance in CT colonography, off you go. So this was my mind map back in 2016 about where I kind of did a brain dump of all the, I don't expect you to read this, but this is just to give you an overview of all the things that I thought I could look at with regards to how radiologists perform in CTC. And for anyone that is interested in getting involved in academia, I can recommend it. It's definitely easier when you do it full time and don't try and juggle a clinical job at the same time. I also had my second son during that research time, which has pros and cons, but also meant that there was a lot of time in coffee shops, kind of chilling with him whilst also trying to write my papers. So one of the first pieces of work I did was a systematic review. So what we wanted to look at is what were the factors that contributed to missed cancers after CT colonography, and what was that missed cancer rate? And that was that is a metric that was already well established for colonoscopy. There's been lots of papers looking at what the interval cancer rates were after a colonoscopy, but there was nothing in the literature for CTC. Really what we wanted to understand is if you've had a CTC and it was reported as normal, what is the rate of that actually being wrong and there being a lesion on that scan? And if there was a lesion, what was the cause of the error? So I did this systematic review. We looked at 13 studies and over 20,000 patients. And the average length of follow-up for all of those studies was about 35 months. And what we found was that there were 29 missed cancers in that cohort, and 17 of them were due to a perceptual error, which is about 60%. And actually, so the majority of cancers that were missed were actually evident on the original scan, but they hadn't been reported. And so this really led to the question of if we can improve the perception and detection of these early cancers or cancers in general on CTC, can we reduce the interval cancer rate? And therefore, can we train radiologists to improve their detection rate and minimize these errors? So this is an example from one of the systematic reviews of a perceptual error, and arrowed on screen is this crescenteric polyp, which is on a fold, has central depression, so we would be concerned that this is harboring a malignancy. And this is an interesting case actually, because this scan actually had a cancer elsewhere on the scan, which was reported, and then this second cancer was missed. And so there's lots of reasons why this could have been missed. It's the perceptual error of looking on folds and dismissing the so-called thickened fold when actually there's a polypoid lesion there. There's also the satisfaction of search, which you'll all be familiar with. So these are the things that we were trying to tease out as possible factors that could be targeted to improve our radiologist performance. So some of the work I did also involved surveying radiologists across the country to find out what sort of training that they had in CTC prior to reporting independently. And I recruited 139 radiologists across the country and asked them a bunch of questions. And what we found was that most of the radiologists had been through some sort of CTC training. So they'd been on a workshop, whether a commercial abroad or here, of 2 or more days. A few people had done a specific fellowship. And the other kind of big group were those who were reporting, doing the job, and then correlating their reports with the endoscopy findings. So I recruited these 139 radiologists from 72 sites across the country, which is shown on the map on screen. And the main part of my research was conducting a multi-center randomized trial looking at the performance of these radiologists. And what we wanted to see was, one, what their performance was at baseline. So after whatever training they've had historically, but before they have any training as part of our study, what is their baseline performance? And the way that I assessed that was compiling a huge database of CTC cases, correlating them with the endoscopy and histology findings, and dividing those cases into 4 tests, which we then administered to these radiologists across the length of a year. So I had 139 radiologists. They were randomized into the control arm or the intervention arm. The control arm are the radiologists that didn't get any training for the whole year. They didn't get their results from the test. They just had to do the test. and the intervention arm did their baseline test. Then they underwent some specific training, which we developed, again, using the knowledge that we had about perceptual errors, things that, sorts of things that are missed. We delivered this training after their baseline test, and then they went on to be tested again at 1 month, 6 months, and 12 months. And then we basically compared what the results were. So what we found in our baseline test cases, which was a test of just 10 CTC cases, there was 19 polyps or cancers in that group. What we found was that the performance was hugely variable. You can see on the graph that we've got people scoring 15.8% all the way up to 89.5%. And the orange bars are showing you the interquartile range. So what we were seeing is that amongst our radiologist cohort, which were experienced radiologists who were reporting CTC already in their clinical practice, that actually when you tested them, this whole group on a set of cases, that actually the variability on the spread in their performance was extremely wide. So clearly there is a need for more and better training. So as I mentioned, I subsequently went on to then test them on a different set of cases, each time at 1 month, 6 and 12 months. And what you can see on the graph on screen is that in the intervention group, which is the blue line on top, so these were the radiologists that came to have our specific training, which was just a one-day workshop at St. Mark's, looking at really difficult cases, training them how to problem solve, how to avoid some of the pitfalls and errors. You can see that at 1 month, they were significantly better when tested. And actually that improvement in performance lasted at the 6-month test, which was a different set of cases, and also at the 12-month test. And actually the odds of detecting a polyp were 4 times higher in our intervention group at 1 month and 12 months. So this is a huge win for the research project and for the study, because we've developed training that we know works, and it works in experienced radiologists. Just as an example of one of the cases, this is a case from the 12-month test, and it's really probably the strongest evidence for our training model. And I hope you can appreciate that here, arrowed, this is a polypoid lesion. It's submerged under tagged fluid. This is the bowel preparation that the patient has to drink. It's gastrographin. And so one of the blind spots is basically not remembering to look under or through the tagged fluid to see if there is a cancer or a polyp that is submerged. And you can see that actually in our training group, in our intervention arm, 88% of them detected that lesion, compared to only 43% of our controls. And that was actually a T2 adenocarcinoma. So missing that has really detrimental consequences for the patient. And it wasn't even just the kind of arbitrary test results. After our radiologists had been to our training course, obviously the knowledge that we'd imparted to them, they were able to take back into their clinical practice. And this is one of several emails that I got after our training workshops from a radiologist that had been to our course, who had applied, you know, the principles that we had taught them to the benefit in their local practice. And there's lots of typos in the email. I've just copied it as it was sent to me. But basically this doctor is thanking us for the course, that it gave him the confidence to report a really subtle lesion, which then gave the endoscopist confidence to continue trying to find this polyp. And I think it was on the 3rd or 4th pass that they eventually saw the lesion that the radiologist had described on the CTC scan, and it did have malignant features. So again, this is a really, really positive outcome for the patient, and it allowed us to see the direct clinical impact of the work that we've been doing. So from my perspective, the research was great, but it was really about seeing how we could kind of get this out to the jobbing radiologists around the country. And so we have been fortunate enough, off the success of the initial trial to get funding from Health Education England to fund a national CTC training and accreditation program. And it's amazing because this program is evidence-based, and it's the first national program of its kind. And because we have this research foundation, it's allowed us to really build on the principles that we established during the academic work. So what we've done is divided all of CTC into two broad categories: technique and interpretation. And the national program will be taking primarily radiographers through module A, which is technique, and then primarily radiologists and radiographers who report through module B, which is interpretation. And so what we kind of decided is that in order to do the best scan, you have to have a really solid understanding of the technique. So radiologists going through the technique module will be able to better support their radiographers in troubleshooting. Radiographers going through it will be able to optimize how they do their scans so that we get the best scan quality, which then optimizes our chances of doing a more accurate read. So we did a London pilot of the national training program, and we have the online element, which I built, and then the practical element, which is we have trainers and assessors who go and assess radiographers, learning how to do the scans. They do their DOPS, they do their reflective practice, etc. The London pilot went very well, so we were able to qualify for a second tranche of HEE funding, which was again incredible. And so we were able to take on a specific e-learning designer that I recruited, who is amazing, and she is also a medical illustrator. So we've been able to completely build a brand around this national training, develop a proper website, and create a digital campus. I'm just going to show you a couple of examples of some of the work that we've been able to do. So we have written and developed 18 units on all topics related to CT colonography. And on screen, hopefully you can see some video playing of an excerpt from one of the units. What we did is get content contributed by different subject matter experts from around the country. So centres that do a lot of CTC, who have consultants that are involved, and radiographers that are involved in a lot of training. We brought them all together into a clinical advisory board, divided the units up, and so they all kind of wrote their units, we edited them. They're supported by real case studies. They're backed up by the literature, and it's allowed us to create a really high quality evidence-based training program. And the other kind of online component of the program is the e-portfolio, which allows us to document the DOPS and reflective practice that I mentioned, patient feedback, all within the same learning management system. So I mentioned that we've got loads of different units. We've got units on standards and guidelines, surgical, post-surgical and normal anatomy, physiology, problem solving on the table as the radiographers are doing the scans, how to do their on-table review, and things like this, how to differentiate cancers from strictures. The advantage of working with a dedicated medical illustrator is that we've been able to create all of our own diagrams specifically for our purposes that highlight exactly what we want our radiologists and radiographers to know. So that's module A, which is currently live, and we have been recruiting onto the new learning management system radiographers from around the country as we start our rollout. And now what I'm focusing on, which will be my life's work, is developing module B, which is interpretation. And so just to show you a little bit about what we are planning to do, this is a screenshot of a prototype that we are working on. The text in red is just to give the answers so that I can go through and test the online form. So what will happen is the radiologist will be looking at a CTC scan on a second screen, and then they will use this interface to document any polyps or cancers that they've seen. And the idea from this is that as you find a polyp or a cancer, you put the image number in, you put where you think it is, you classify it, you measure the size, and you get automatic feedback on your performance. When I did this as part of my research, because obviously I had to mark all of the tests that we gave to our trial participants, I had to do all of this longhand, like just with pen and paper and Excel. So I've got thousands of rows of data, and it was extremely time consuming. So obviously for a national program, that isn't going to work. So we are building this to allow us to automatically mark our radiologists answers, automatically give them feedback. We can share with them the histology, the endoscopy findings. We can give them automatic feedback on learning points. We can give them feedback on tips and tricks. And also, because all of this data now will be collected automatically, we can run powerful analytics to look at, assess people's weaknesses, assess which cases are more difficult, which cases people are passing more easily, and then continue to tailor the teaching. So in the next, I think I've got about 4 months left before this will be finished. And then hopefully we'll be able to add that to the digital campus and start to roll that out. And what we envision is that will be available for radiology registrars, as well as radiology consultants who are already practicing CTC. And just as we round up recently, the last couple of weeks, I submitted our program for an e-learning award for learning technologies, which is an industry award. It's nothing to do with the NHS, but I thought I would have a go and see how we got on. And they had over 450 submissions from 23 countries around the world. And they have lots of different categories, and I specifically put us in for the excellence in design of learning content, and we were fortunate enough to be awarded the Silver Award, which is a huge achievement for the team, and really just great recognition of the work that we've been able to do and what we've been able to put together. So just in summary, the national CTC training that we've been developing is really unique because it's evidence-based. It's based on my PhD research, which is based on the research of 2 of my supervisors, which is based on the research of 1 of their supervisors. And so this has been a long time in the making, and it's incredible to see how each of those stepping stones is getting us closer and closer to the goal of having easily accessible, evidence-based, interactive, really engaging, high-quality training in CT colonography. And what we really want to do is reduce that variability that I observed earlier on in my research, so that we're really raising that minimum standard of reporting and polyp detection. You know, and ultimately the whole point of that is so that we can improve the patient outcomes, we can improve the patient experience. And I would just like to acknowledge the following people. David and Andrew are my PhD supervisors, and the other people on screen are part of the steering group for the national programme. I also have to thank the Clinical Advisory Board, who have written the content which we use in the programme, and also our funding from Health Education England and Fortitude Colon Cancer, and particularly Fortitude, who funded my PhD, without whom the project would never have gotten off the ground. So thank you very much, and I'm happy to take any questions.